Hello, everybody. In this lecture, we're going to be looking at evidence-based practice. And what I'm trying to accomplish in this is to give you some tools for use in this course, particularly when you write your paper. Let me just say a little something about the paper. Your paper is going to involve asking some clinical question. It can be anything, and we'll talk in detail in the class about it. But you're going to ask some interesting clinical question, interesting to you. And then you're going to look at research literature to try to find the best possible answer or answers to that question. And so you're going to go through a series of steps in accomplishing that. And you're not only going to do it in this class and for that paper, but throughout your career. When I think about my career and the things I did to work with dysphagia, many, many years ago, it's really very different from what I do now. And how did those changes take place? Well, partially because I went through various courses and conferences and heard things that seemed to make sense, partially through just day-to-day experience, partially because I would work in some place where they said, this is the way we're going to do it, but also largely through asking questions as you're going to be doing, and we're going to go through an example today, and going to literature and trying to find, for example, the most efficacious form of therapy to treat a given impairment. So we're going to go through a process. Let me share my slides here to start that process off. And enlarge them, and there we go. So we're going to work through how we, as clinicians, refine and update our clinical practice standards. That is what we do in our clinics to assess people, diagnose people, formulate treatment plans, etc. And we're going to work through an evidence-based practice example. And here I'm going to elaborate on this slide a little bit to tell you where I'm coming from. Let's start by this. This will make sense to you, I believe. A conventional wisdom holds that if a person aspirates significantly and there's nothing you can do to prevent them from doing this, no therapy, no compensation, they're going to aspirate. And part of that would be because they also have an etiology for the dysphagia that doesn't get better. Some things like a stroke start severe and get better. And some things like Alzheimer's disease start mild and get worse, or ALS, or sometimes multiple sclerosis. Many things start in a mild way and get worse. So we're talking about a patient who's not going to get better. So if they're asked now, but they can eat, but with aspiration. And so the conventional wisdom is that such a person should be NPO. Now, NPO means the translation into Latin is known, N-O-N, per, P-E-R, oral, nothing through the mouth. We translate that to be nothing by mouth. So that is what NPO is. We'll use it all the time in this course, and you'll use it in your practice as well. So the conventional wisdom would be that such a person should be NPO and then fed with some sort of tube feeding. And typically for long term, that would be a tube that goes through the abdominal wall. And that's called a PEG typically, or a G-tube sometimes, or a gastrostomy tube. So anyway, that's how we were trained. Jerry Logeman, the originator of the textbook we used to use, and who's now, it's been about 10 years since she passed away. She was very, very black and white about that. If you have a patient who is aspirating, they cannot eat. Done. Okay. Because what's the problem with that? Well, they are likely to develop aspiration pneumonia and to get very sick from it and potentially to die from it. And so she just felt SLP should not be involved with that at all. So she was big on NPO and PEG feedings for people who would have chronic aspiration. That's the way we were trained, and I think SLPs did it all the same. Well, about 30 years ago, I'd say, things began to change in medicine a lot, so the patient had the right for the information about them, or the patient or the loved ones, if the patient couldn't make the decision, and to make their own decisions. So they didn't have to have tube feeding, and they could eat if that was their choice to do so. So we became, as SLPs, involved with many people who are someplace on a continuum, some who are perfectly happy not eating and having tube feedings and taking a chance on a longer life, and others who said, I don't really care about that, I'm just going to eat. And so we had people all across the continuum, and we needed to learn a more sophisticated way to manage them. So since we got rid of the simple answer to the problem, we needed to start to revise our clinical practice standards quite a bit. And so the question I'm asking here as an example would be, what is the most efficacious approach to the management of such a patient in an acute hospital setting or outpatient? Now, the reason I'm asking it that way is I'm kind of coming from a personal place, and as I give you this example, that's where I worked. I worked in acute care hospitals and in outpatient settings, mostly, also some subacute. But I'm just going to simplify it right now and say we're talking about acute hospitals where patients go initially when they get sick, and also outpatient settings where we did a lot of modified barium swallows on patients who were sometimes at home, oftentimes in skilled nursing facilities chronically. They would be there because they're not going to be able to get better enough to go home. And so we had many opportunities where we saw people who weren't going to get better, and they did aspirate, and we made recommendations, and then we nuanced it to address more issues than just if they're aspirating or not. And so we needed to be able to actually to advise people, why can't I aspirate a little bit, or why do I have to have the tube feeding, you know? So the first step in determining an answer to a clinical question like the one I'm posing is to go out and find one or more empirical studies that address the question. What's an empirical study? It's a study where there is a hypothesis, a research question. They go get some subjects, they do something or measure something, they do some statistics, they come up with an answer. In other words, it's not just an opinion piece or a philosophical piece or well, it could be a case study, can still be considered an empirical study, but generally a case study will not give you much strength of evidence. So that's what we would go out and look for, is the best studies we can find. And then after we find such a study, or at least one, for what we're doing today, it's going to be one, we go through some questions. And here are the questions. And these are the questions that you will use in your future as an SLP. Pretty much. I mean, it's kind of that simple. It's not really simple, but it boils down to looking at these questions, and you're going to do the same thing for your paper. So number one, you ask yourself, how similar is the research question posed in the study to your clinical question? You know what my clinical question is. It has to do with the efficacy of recommending NPO status and PEG for patients who are found to be chronic aspirators and that are in the acute hospital setting or the outpatient setting. So we evaluate that. Now, we're talking about evaluating research, but that question is really one that a statistician, for example, would not be able to address at all. Really, an SLP could. An SLP who has this experience could do it. So you will be able to address that question better than most. Second, can we generalize from the research population, that is the population that was used in the study, to our own population? My population that I'm interested in is acute care patients and also outpatients that I would see. Variety of etiologies. I mean, they come with every kind of etiology. And the research population is whatever they chose to look at. And you'll see when we get to our research study what in this particular study they chose. Can we generalize from the study procedure? Now, what's the study procedure? The treatment or the management strategy that they tested, the assessment method they employed. Can we generalize from how they did the study in terms of how they tested or what treatment they delivered to the clinical procedures that we actually use in our clinic and that we're interested in? Fourth, was the dependent variable one that was actually clinically valid, of interest, or of some significant value in the lives of patients? Now, what's the dependent variable? Generally, I think the simplest way to think of that is it's the outcome variable. And so there are some outcome variables that are very impressive. For example, if you just said return to oral feeding or not, that's an outcome variable. And if somebody could actually return to oral feeding from not feeding, that's pretty impressive. There are others that are still outcome variables. Oh, no, I'll give you an example. There was one study that we'll refer to later in the course in which they did this treatment called thermal tactile stimulation, rubbing a cold mirror on the side of the throat inside to speed up the pharyngeal swallow response in somebody who has a delayed pharyngeal swallow response. And John Rosenbeck did this study a number of years ago. And what he did was he measured the delay that they had in milliseconds with an NBS, of course, that's the only way you could do it. And then he stimulated right away for a few minutes, and then he remeasured. So it was measure, stimulate, remeasure. I mean, they could see a patient, they could do one of these subjects in a half hour or so, and they got all their data from that individual. And what he found was that it did indeed speed up, statistically significantly speeded up the delayed pharyngeal swallow response. However, and that's good, so great. What he didn't measure, because it would be much more difficult to do it, was a more of a functional outcome. Like, did they eat better? Did they eat with fewer incidents of complications, of aspiration, et cetera, et cetera? So you can kind of see where I'm going with that. So there's some variables that are more, I'll just use the word impressive than others. They would tend to be, such variables would tend to be meaningful variables to non-professionals. Like, you understand the meaning of a delayed pharyngeal swallow response and how it might be measured. But when you tell, a relative that, it's not going to mean very much to them. You could try to explain it, but if they could actually eat, that means something. So we have to consider the dependent variable and its nature and its functionality. And again, that's more for an SLP to determine that. So we're going through things, all of which you can do. And then finally, we come to something where a statistician might be a little bit better, but I think you can do it. Were the controls for other sources of influence on the dependent variable adequate? Well, the thing that makes this less problematic right off the bat is if you have a study that has randomization to treated and untreated groups, something like that. All of a sudden, you've helped to control a lot of variables that could have affected the outcome. And if you have self-selection, for example, that's a little bit different. So that is a statistical and experimental design issue, but I think you have the knowledge to address that well too. And we'll practice it. All right, now, you remember my clinical question having to do with how efficacious it is to more or less, let's say, insist upon PEG and NPO status for patients who are going to be chronic aspirators. Here's the study I found. It's a 2003 study. You have it. Hopefully you've read it before you listen to this lecture. And the title is Percutaneous Endoscopic Gastrostomy, which, by the way, is where they get that word PEG. Percutaneous, through the skin, endoscopic, they use an endoscope to do it, and it's a gastrostomy, basically a tube that goes through the abdominal wall. And here they give us the answer. They don't ask the question. Percutaneous endoscopic gastrostomy, i.e. PEG, does not prolong survival in patients with dementia. Now, when we talk about the population, the nature of the population, we're going to address this with dementia issue quite a bit. It was in Archives of Internal Medicine. What was that, 18 years ago, I guess. It changed the way I thought about it quite a bit at that time. Okay, so now let's look at the research question versus the clinical question. I'm going back to that slide and just ticking through those, I think, 5 bullet points. My clinical question, so I'm just giving it to you again. Does NPO status combined with PEG feedings improve survival among patients whose aspiration cannot be prevented and who are seen in an acute or a hospital or outpatient situation. And when I say cannot be prevented, I mean it's chronic. It's probably not going to go away. And versus the research question asked in that particular Murphy and Lipman study, does gastric feeding provided by PEG tube prolong life in patients with dementia? Now, let's look in more detail at the population of patients in the study versus the population that I work with. These are the relevant characteristics of patients that I typically have worked with, and that, these are the ones that I was interested in. They had chronic handicapping dysphagia, and you know what that means now, caused by such things as advanced Alzheimer's disease, multiple stroke syndromes, ALS, which is clearly a progressive disease, Parkinson's disease, progressive disease, multiple sclerosis, again, a progressive disease. And there are others too, but it's a mixed bag of people who come in and to acute care with illness. Oftentimes, by the way, they're admitted with pneumonia, and in their background, you see that they have some etiology of dysphagia and in fact have a history of dysphagia. And sometimes they're the same patients, but they're in a skilled nursing facility and we're seeing them, as outpatients. The next bulleted item shows the characteristics of the patients in the study. They were all veterans. They were all diagnosed with dysphagia. They were all diagnosed with advanced dementia. And I should say, by the way, that many of these patients in our hospitals that we would see in an acute hospital setting or an outpatient, many, I'm going to say more than half, do have dementia. And exceptions would be like a patient with ALS. They can have completely normal cognition and die from their dysphagia. So that would be an exception. But most of the others do have dementia. Okay. They have no other disease contributing to the dysphagia. They are referred for a PEG. That's kind of how they got in the study. The physician said, maybe we better do a PEG on this patient. They had no contraindication, I should say, to conscious sedation. That's a light sedation. Some people, their heart or general health may be so poor that they can't even tolerate a light anesthesia. It takes about 10 minutes to put a PEG in. They do have to be, they're not completely out, but they certainly won't remember it. And they're certainly, they're not uncooperative. They cooperate with it, but they can actually follow some instructions, open their mouth and stuff like that. And then their life expectancy is considered to be at least 30 days. I would say that pretty much that describes the population of patients that I was interested in. The one thing that is a difference is that these were all veterans in the study. Of course, not all patients that you see in a general acute hospital or from in an outpatient setting would be veterans. Some of them would be. Is that a key difference? I'm not bothered by it myself. To have that in your history that you were a veteran, you were in the Army or the Navy or whatever, and later on, I don't think it would. I cannot imagine that it would make a difference. It might be weighted toward males, although certainly we have female veterans and many of them. But I would guess it's more heavily. A larger percentage of the study population was male than in my population that I'm interested in, which is the general population, which would, I don't know, be close to 50-50 male, female, I think. But I'm not bothered by it. I think it's okay. So, okay, now, so we've gone through that. Now, the study procedure. The relevant characteristics of the procedure in our hospital practice, mine, is to recommend NPO and PEG if the patient is found to have a chronic handicapping dysphagia with aspiration that cannot be prevented. Basically, that's it. We're always going to recommend PEG. They're not always going to do PEG, but we're always going to recommend it. And now let's look at the study. The relevant characteristics of the study procedure was to recommend NPO status and PEG in patients who met the criteria. And they did all have dementia. So I think it's the same. I'm not, as a clinician, I'm not bothered by the difference there between the study and my own personal reality at all. I think that if there was something that I learned from the study that I could be convinced of for all the other reasons, I'm not bothered by this at all. It seems pretty much they did the same thing as we do. Was the dependent variable one that was actually clinically applicable? The dependent variable in the study was duration of life in days following the PEG placement. So they had put the PEG in, and then they measured how many days they survived. And the independent variable, of course, was the placement of the PEG. Now, how did that decision get made? It was recommended, first of all, for good reasons. And then the patient and family consented to the PEG or not. That's how people got into the study. So they had two groups, one with PEG and one without. How they get assigned to the group, not randomly, self-selection. I want a PEG or I don't want a PEG. And of course, if you don't have a PEG, then you're going to eat because you won't survive long without it. All right. Were the controls for other sources of influence on the dependent variable adequate? Well, this one I always like to have a conversation with a group like you, because you will come up with some things that I probably didn't think of. And so when we discuss it, we will do that. But I'm just going to jump out and say for starters, no, because it wasn't randomized. They couldn't possibly be completely adequate because it wasn't a randomized study, meaning the patients self-selected themselves for the two groups, control, or you could say experimental with the PEG, or control without the PEG. And you can imagine all kinds of other kinds of differences that might have been in play then that could have affected the outcome. That is how long they lived after the PEG. What kinds of things? Well, it might be that the people who chose the PEG were sicker, or maybe not, I'm not sure. It might be that the people who chose the PEG were not as depressed. I don't know, you could think of a bunch of things. I'm sure we could come up with a list of pretty viable possibilities that of other factors or variables that could have affected the outcome and made a difference or no difference. Okay. What was the study conclusion? The decision to place a PEG in study patients did not significantly improve the survival of the PEG patients. And that was actually shocking because the whole premise of the recommendation to make a patient who chronically aspirates NPO and give them a PEG is that they would live longer, but not according to this study. So of course we want to discuss that in detail now when we get together, but there you have most of the lecture, and here's some things I want you to consider before we discuss. When we find a handicapping dysphagia in patients who have chronic dysphagia with aspiration, what options are available to recommend? We want to talk about more how do we as a clinician have the knowledge we got from this study and studies like it, although they're not that many, and how does that play into how we make recommendations? Should the PEG be recommended always, never, or sometimes? And I'd like you to be able to think about and then explain in class your rationale for always, never, or sometimes. And beyond making the recommendation, think about knowing what you know from this study alone. What is the SLP's responsibility in this whole decision-making process as to whether a patient is going to end up with a PEG or not? And I do believe that's the last slide. Let me just double check that. Yes, it is. So I'll leave you with those questions and then we'll discuss them when we come back to class. And I'm going to stop sharing and turn our video off. Bye. See you later.